صباح الخير. I'm really honored to be with you today. Myself, I am Dr. Ammar Abdulaziz, pediatric ophthalmologist and neuro-ophthalmology consultant at Nur Yemen Eye Center and assistant professor at Faculty of Medicine, 21st September University. I'd like to speak about very basic topic, which is oculomotor or ocular motor nerve pulses. It's very basic, but it's also very important because, as we all know, around 60% of neurological diseases will manifest with ocular manifestation, whether patient will present with vision loss or visual field defect or cranial nerve pulses, as I will show in this presentation. So it's extremely important for all neurosurgeons to have a complete ophthalmological evaluation for the patient, especially preoperatively for the medical legal purposes. So you need to know if the baseline visual acuity of the patient, if the patient is having any visual field defects. So post-operatively, the patient will not claim that he had these problems only post-operatively. So that's really very important. So this is the outline of my presentation. So starting with the anatomy. So as we all know, this is the globe from the lateral side. This is the lateral rectus, superior oblique, medial rectus, inferior oblique, and inferior rectus. And here are the cranial nerves that is supplying these muscles. Oculomotor nerve is responsible for supplying 4 of the 6 of the extraocular muscles. And lateral rectus is supplied by abducens nerve, and superior oblique supplied by the trochlear nerve. So here also, that is another diagram showing the extraocular muscles. So superior rectus will elevate the eye, inferior rectus will depress the eye, lateral rectus abduct, medial rectus adduct. Superior oblique will intort and depress the eye, and inferior oblique will do extorsion and elevation of the eye. So coming to the oculomotor nerve. So oculomotor is responsible for all the muscles except superior oblique and lateral rectus. And because of that, patients with oculomotor nerve palsy will present with outward and downward deviation of the eye, because lateral rectus is still working and superior oblique, which is a depressor, it's still working. And also third nerve is responsible for supplying the levator palpebrae superioris, so patients with third nerve will present also with ptosis. That is also the autonomic parasympathetic innervation that's coming from the third nerve. It is responsible for the sphincter pupillae muscle in the iris and the ciliary muscles. Because of that, patients with third nerve, especially the compressive lesions that will affect the peripheral parasympathetic nerve fibers, will come or present with pupil-involved third nerve palsy. So the clinical classification, we have complete versus incomplete palsy, and pupil sparing versus non-pupil sparing or pupil involved. So here again the non-pupil sparing, here pupil involvement in patients with compressive lesions like posterior communicating artery aneurysm, that is compressing the peripheral fibers, whereas in patients with microvascular causes like diabetes, hypertension, will have ischemic damage of the central fibers, and peripheral fibers usually are preserved. Because of that, patients will have normal pupillary reaction. So again, complete pupil sparing, usually it has ischemic causes, complete involving the pupil, mostly compressive lesions, rarely malignancy. Also traumatic causes can cause complete third nerve palsy with pupil involvement. And incomplete pupil sparing, usually ischemia of various distribution of the third nerve. So that is a case of patient with complete third nerve palsy, ptosis, with exotropia, with hypotropia, with pupil involvement. Here again, right third nerve palsy, limitation of elevation, limitation of depression, limitation of adduction, normal abduction because lateral rectus is still working. That is a patient with partial third nerve palsy. We can figure out variable ptosis limitation of elevation but not complete limitation, limitation of depression, mild limitation of depression, and mild limitation of adduction. That is a case of traumatic third nerve palsy with pupil involvement. So diagnostic workup for all patients, we need to do dilated eye examination, laboratory test for patient with microvascular diseases, inflammatory. Also we need to do some workup, imaging, of course, brain MRI with contrast, and for intracranial vasculature, we need CTA or MRA to see if there is any aneurysmal compression. So regarding the management, observation is appropriate, especially in ischemic cases, because they will resolve spontaneously within 3 to 6 months. Temporary measures, we can do occlusion, we can use Fresnel prism to relieve the diplopia in those patients. Botox injection can be used sometimes, and surgical treatment. That is the definitive measure for patient with non-recovering third nerve palsy with a stable deviation for at least 6 months. So that is a case of left third nerve palsy that is surgically treated. That is again another patient with incomplete third nerve palsy, surgically treated also. And this also the same thing. Coming to trochlear nerve. So as we all know, it is a somatic motor nerve, innervates only superior oblique muscle, and it has the longest intracranial course of any cranial nerve, only cranial nerve that exits brainstem on dorsal side, but decussates and curves around the ventral side. And it is more susceptible to damage in the setting of head trauma. So etiology of cranial nerve palsy, 75% congenital, 25% acquired. Most commonly the trauma is the most common cause of acquired fourth nerve palsy. So patient usually will present with vertical and torsional diplopia. He will see two images vertically displaced, and one of them is extorted. So that is the torsional diplopia, and that is the vertical diplopia, and it's more in down gaze. Patient also will have hypertropia, contralateral head tilt in cases of unilateral fourth nerve palsy. So that is a patient with right fourth nerve palsy with right hypertropia. Here we can see inferior oblique overaction in the right eye. So management in congenital palsies, usually we don't need any workup, but in acquired cases we need workup to identify the cause. Again, we will check the blood pressure, doing the labs, neuroimaging, and comprehensive neurological examination. For acquired cases secondary to microvascular disease, again resolution will happen within months. Patching, prism, surgery if symptomatic. Those are cases of trochlear nerve palsy that is treated surgically. Coming to the last cranial nerve, abducen sixth nerve palsy. Etiology, microvascular ischemia, hypertension, diabetes, hyperlipidemia, compressive lesions like malignancy, middle ear infection and aneurysm, and of course increased intracranial pressure, which will cause false localizing sign. It might cause unilateral or bilateral sixth nerve palsy, and the patient will present with diplopia. And of course trauma and inflammation, especially in young patients with no history of trauma. We suspect multiple sclerosis or vasculitis of any cause. So in sixth nerve palsy, patient will have left inward deviation and limitation of abduction in the affected eye. And patient will present with binocular horizontal diplopia. Diagnostic workup, as usual, ophthalmological assessment, extremely important to know if the patient is having papilledema or no, and laboratory test for patient with suspected microvascular etiology. Coming to the imaging, MRI brain for the compressive lesions or traumatic cases. Management of abducen nerve palsy, again, observation with monocular patching, especially in cases of the patient with microvascular etiology, because in 90% it will recover spontaneously, only with the control of the microvascular risk factors. Botulinum toxin, sometimes used to prevent the contracture of the medial rectus muscle, and surgery. Surgery, we have two types. If the patient is having paresis, That means still lateral rectus has a residual function. We can do weakening of medial rectus, strengthening of the lateral rectus, but in cases with complete palsy, we need to do something called transposition surgery. We will transpose superior rectus and or inferior rectus to the lateral rectus to abduct the eye. So that is a patient with 6 nerve palsy that
Doctor,
is...
1 minute.
I'm finishing. That we use Fresnel prism to relieve the diplopia for the patient. And this is a patient with complete 6 nerve palsy, left esotropia with complete limitation of abduction in the left eye, and he was treated with medial rectus recession and superior rectus transposition to the side of the lateral rectus to abduct the eye. Take-home messages: neuroimaging is not necessarily initially in patient with mononeuropathy more than 50 years with microvascular risk factors, but it is important in patient with multiple cranial nerve involvement or third nerve with pupil involvement, or if there is no improvement within 3 to 6 months, we need to do neuroimaging for the patient. MRI is the gold standard neuroimaging. Multiple microvascular risk factor will increase the prevalence of cranial nerve palsy, and longer duration poor control of diabetes will increase the risk in ischemic cases. Spontaneous recovery is the rule in ischemic cranial nerve palsy, and temporary measures we can use, and definitive measure is the surgery in cases with no improvement. Thank you.
Thank you, Dr. Amr, for nice presentation.